Good morning, sirs. My name is Krithika. I'm from Regional Eye Hospital, Kurnool. So my presentation is on a clinical study on ocular Stevens-Johnson syndrome. So Stevens-Johnson syndrome is a rare and severe acute blistering disease that affects skin and at least 2 mucous membranes. It is most commonly triggered by drugs and infections. Ocular involvement occurs in up to 50 to 80% of cases and contributes significantly to long-term morbidity. So my objectives are to evaluate the ocular manifestations in patients with Stevens-Johnson syndrome spectrum of disease, to assess visual outcome and complication during follow-up, to highlight the importance of early ophthalmic intervention in prognosis. So this is a prospective observational study done in Government General Hospital, Kurnool, of 10 patients clinically diagnosed with Stevens-Johnson syndrome spectrum for a duration of 1 year. So parameters assessed were visual acuity at presentation and follow-up, ocular surface changes were noted, corneal involvement and adnexal complications were noted. So interventions that we have done are mostly medical management, corticosteroids, cycloplegics were given, vigorous topical lubricants, antibiotics and prevention and treatment of symblepharon. So these are the cases who have developed Stevens-Johnson syndrome. The first case was developed secondary to phenytoin. Second was developed secondary to carbamazepine. Third one was secondary to painkiller. The patient was not sure of which tablet it was. This fourth case was secondary to ciprofloxacin tinidazole combination. Fifth case was secondary to Ayurvedic medicine, and she has taken this Ayurvedic medicine for some skin lesion. And case 6 was developed secondary to cotrimoxazole. Case 7 was secondary to amoxicillin. And all these 3 cases did not have much ocular complications, only skin lesions were present. So this was secondary to fluconazole. Case 9, there was no reason, idiopathic. And case 10 was secondary to oral diclofenac. So in her hospital, 10 patients were diagnosed as spectrum of Stevens-Johnson syndrome during 2024 to 25, in which patients with ocular involvement were only 8. So on follow-up, we have done follow-up for over 1 year. We can see the epidermal peeling has reduced and all the healing has started. So in acute phase findings, 80% of them had conjunctival congestion, 37.5 had pseudomembrane formation, 25% had epithelial defects, and the least were mebomitis. In chronic phase findings, 80 of them had dry eye, 37.5 had trichiasis, 25% had symblepharon formation, 25 had corneal opacity, and also meibomian gland dysfunction, and 12.5% developed punctal autoocclusion. So the visual outcome, only 25% had visual impairment, that was because of corneal opacity formation, and 75% did not have any visual disturbances much. So coming to discussion, Stevens-Johnson syndrome is a dermatologic emergency characterized by the presence of epidermal and mucosal bullous lesions involving less than 10% of the total body surface area. So we have a Stevens-Johnson toxic epidermal necrolysis spectrum, in which if it's less than 10%, we call it as Stevens-Johnson. If it is between 10 to 30%, then it is an overlap of Stevens-Johnson with toxic epidermal necrolysis. If it is more than 30% of total body surface area, we call it as toxic epidermal necrolysis. So causes of Stevens-Johnson mostly is because of drug induced. So we have allopurinol, anti-epileptic drugs, sulfa group of drugs, nevirapine and NSAIDs, meloxicam, piroxicam. So infectious causes, we have mycoplasma pneumoniae, cytomegalovirus, herpes simplex, streptococcus, Yersinia, adenovirus, measles and varicella zoster. So according to duration, we have the clinical presentation. On day 1, a patient can develop conjunctivitis, subconjunctival hemorrhage, conjunctival membranes. On day 3, conjunctival ulceration, superficial punctate epithelial erosions, epithelial defects. On day 4, there can be symblepharon, ankyloblepharon formation, trichiasis, dry eyes on week 5 to 6. There can be punctal occlusion, anterior blepharitis also during week 5 to 6. On week 7, there can be some conjunctival scarring. During month of 3rd to 4th, there can be lid margin keratinization, meibomian gland dysfunction, corneal opacification. And 5th to 11th month, we have dry eye, dystrichiasis, limbal stem cell failure, and corneal vascularization. So during acute phase, we'll have to do prompt ophthalmic evaluation, preservative-free lubricants has to be given, topical steroids, cycloplegics, and bandage contact lens if needed. During early chronic phase, lubrication, anti-inflammatory therapy, simblifron lysis, tarsorafy if needed. During late chronic phase, immunosuppression, reconstructive surgery, limbal grafts, and topical transretinoic acid. So conclusion, immediate ophthalmic assessment should be standard for all cases upon diagnosis, regardless of apparent severity of skin involvement. A multidisciplinary approach has to be done, and long-term follow-up is critical even after the acute phase to detect and manage late onset ocular disease effectively. Thank you, sir.
So Krithika, good study, 10 cases. For the dry eye, you did the objective or the subjective test?
So we have started the patient on topical lubricants, sir.
No,
Regular follow-up, initially when the patient was admitted in the hospital, so it was like, I personally
how you confirmed your diagnosis?
Dry eyes.
It was mild, moderate, severe?
Yes, sir.
Accordingly, which lubricants?
Type of lubricants.
Okay, thank you. And any more questions?
Yeah, Krithika, I have one question. In your cases, beautifully documented. You said in your treatment you use only the medical management,
yes,
like
sir.
topical steroid
Yes,
and all. Was there any cases where like amniotic membrane graftings and surgical management was also required? And what were the sequelae of all those patients? Do they have any scarring or any simplifrom in the follow-up?
So one patient had developed simblifron, sir. That was very mild. So to prevent the further development of simblifron, we had done sweeping of the fornices with the glass rod, sir. 2 patients had developed a corneal opacity, sir. And that was not involving the pupillary axis, sir. So vision was not much threatened, sir.
Okay.
Actually, I'll like to ask the same question which Dr. Moore asked. Was the same lubricant used for all the patients, or did you decide according to the severity which lubricant has to be used?
So we concentrated on the preservative-free lubricants, sir. Apart from that, sodium hyaluronate was suggested for all kind of patients. We had also given gel type, sir, for applying.
Right. Okay, thank you.
Thank you, sir.